Excuse me, ladies and gentlemen, and thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. You may submit your questions electronically at any time using the chat pod located to the right-hand side of your webinar platform. You may also download a copy of today's slides using the Files pod located directly beneath the slide presentation. It is now my pleasure to introduce Ms. Brigitta Kraft. Ms. Kraft, you may begin.
Hi, thanks, Brad, and welcome everyone to the TeamSTEPPS for Office-Based Care online webinar. Today, we'll be discussing and exploring innovative training techniques for TeamSTEPPS for Office-Based Care. As Brad said, I'm Brigitta Kraft, your host, and one of the course directors and facilitators for the TeamSTEPPS for Office-Based Care online course. We're really glad you could join us today. And so for those of you who are already enrolled in a cohort, this webinar is part of a library to support all of your work in the TeamSTEPPS for Office-Based Care online course. The webinar and others are part of the curriculum and will be useful for you in obtaining your Master Trainer designation once you successfully complete the course. For those of you who are not enrolled in a cohort, this webinar will be added to the online TeamSTEPPS webinar library as a resource as you continue to spread TeamSTEPPS throughout your organizations. I'd like to extend particular thanks to the Agency for Healthcare Research and Quality, which is part of the Department of Health and Human Services, for funding the TeamSTEPPS for Office-Based Care online work. We appreciate the work they've done moving this ball forward in the patient safety and quality improvement field. So I'm just going to review a few rules of engagement that Brad mentioned before we kick things off. You can listen to the audio on this webinar in two different ways. You can do so through the phone, and if you do this, please remember to mute your computer speakers, or you can listen through your computer speakers. If you have any questions during the presentation, please feel free to chat them into that chat area on the right-hand side of your screen at any time. We'll be doing a Q&A at the end of the presentation. Now, if there are more logistical questions, we'll answer them right away, but if it's discussion-based, we'll save it to the end. This webinar will be recorded and archived, and in addition, you can download the slides, as Brad mentioned, via the Files pod. Finally, for those of you attending this live, please keep an eye out for the evaluation, which will be emailed to you after the presentation. And now it's my pleasure to hand off to Ross Ehrmantraut, our guest speaker. Ross is no stranger to TeamSTEPPS, the advantages to effective communication and teamwork, and the importance of interactive training and learning. Ross, I'll turn the program over to you and allow you to introduce yourself.
Thanks, Brigitta, and welcome everyone. As Brigitta said, I'm Ross Ehrmantraut. I'm a nurse by background, and I've worked in the University of Washington Health System since 1984. I started out as a new graduate in the Regional Burn Center at Harborview Medical Center, which is one of our hospitals, and spent about 9 years there, 9 years in the trauma ICU. I was the critical care educator, and then I got involved in patient safety around 2005 and was the patient safety officer at Harborview for almost 10 years when I started teaching TeamSTEPPS back in 2009. Since the last 3.5, 4 years, I've taken over the role as clinical director of team performance for all of UW medicine, trying to implement TeamSTEPPS throughout our health system, not only within our hospitals, but in our clinics as well. And I officially work for the WWAMI Institute for Simulation and Healthcare, which is our simulation center for UW Medicine. So UW Medicine consists of 4 hospitals and over 200 clinics throughout not only the Seattle and Washington area, but we cover a 4-state region. We cover Alaska, Idaho, Montana, as well as Washington. We have, like I said, multiple clinics and 4 hospitals in our system. Today what I'd like to do is just talk about how do we get innovative with our training when we're working with those outpatient areas, the primary care clinics, the larger specialty care clinics, and how do we take advantage of the short time periods we may have for training. And so what I'd like to do is just talk about how UW has enhanced our training to reinforce the use of the TeamSTEPPS tools in different settings and multiple audiences through short, high-impact sessions, and that high impact is a big part of this. Identify low-tech simulation exercises that can be easily customized for training in the outpatient setting, and I'll give you examples of those as we go, and discuss quick-win tools such as closed-loop communication, SBAR, CUS, briefs, huddles, and debriefs. Now, when I looked at the registration, I noticed that a fair amount of people are fairly new to TeamSTEPPS. So I just wanted to make sure everybody's familiar with the TeamSTEPPS logo here. And TeamSTEPPS, which stands for Team Strategies and Tools to Enhance Performance and Patient Safety, has 5 major concepts. One is team structure, and then the other 4 are leadership, situation monitoring, mutual support, and communication. And with each one of those areas, there are a set of tools and concepts that we can integrate into our daily practice to improve communication and teamwork. So this is how we go about it at the UW, at University of Washington. When we have short time to meet with people to discuss TeamSTEPPS, we want to focus on these tools because we personally believe these tools can get the biggest bang for your buck very quickly. Little disclaimers, handoff's a little bigger deal, so that it's a little harder to do in a 60 or a 45-minute session. But the rest of those tools, you can make a quick impact by using some short exercises and telling some stories. As we roll out TeamSTEPPS throughout our system, we've learned that systematically going through the tools has been very effective for us. And we've broken them down into 100-level skills, 200-level skills, and 300-level skills. And it's just like when you went to college. Your 100-level course you take first, then you move on to the 200 level, and eventually 300 level. If you notice under the 100-level skills, those first 5 tools are individual skills. Those are something you can teach, and people can start using immediately if they're not already. And we focus on using them 100% of the time, not 95% of the time. It has to be 100% of the time. So one of the things that we discuss quite frequently is people will say, hey, can you come teach us TeamSTEPPS? And we have 60 minutes to do it. Well, no, I can't come and give you TeamSTEPPS in 60 minutes. What I can do is teach you some of the tools in TeamSTEPPS in 60 minutes, and then focus on, especially those 100-level skills, how do we get those quick successes? But we all know there's plenty of issues out there trying to get this training to occur. Getting anything with short training sessions without closing the clinic or conducting retreats on the weekend. And ultimately, that's the dream, right? Being able to close the clinic for 4 to 8 hours and then spend some serious energy on this. A lot of our clinics have larger have staggered start and end times. So you start looking at some of the tools. There's pushback. I know that there's others out there, other issues that occur, and if you want to share those in the chat box, that would be great. Another one we run into all the time, and I'm sure this is pretty common with many of you, is just trying to get people engaged, whether it's providers, the staff, whoever, just leadership, trying to get them engaged in this process. So we've worked on that over the years. And what we've learned is, first of all, you have to have leadership support. They can't just say, hey, it's a great idea, go forth and prosper. They have to make sure that we're going to have providers and administration on board with this, no matter what the training looks like. We work around the clinic schedule, which is, it's not the best for us all the time, but you got to tap into those times that are staff meetings. Get those 45 to 90-minute sessions. Take advantage of any time they make available to you. One of my favorite groups that I work with, it's a huge East Side specialty center, has multiple specialties in this 35,000 square foot clinic. Will have their things early in the morning before clinic opens or after the clinic closes in the evenings. That way, the stress level has decreased significantly among the providers and the staff. And you may have to do the same training multiple times to deliver the message to everyone. You're generally not going to get everybody at one shot. Like I said, the best possible scenario is those retreats outside of clinic times. And we've done some places that have got their staff and their providers to show up for 2 hours, 4 hours, and 8-hour sessions when the clinic was closed, and you can really make a huge impact on that. Other things we've learned about it is everyone needs to find value in the tools and the concepts being introduced. I work with a woman's maternal health physician, and he calls it WIFM radio. It's basically what's in it for me. Everybody wants to know what's in it for them, and so you have to make sure this training and the use of these tools are going to be beneficial to whoever is involved. We don't believe in icebreakers, although a lot of our exercises come across as icebreakers. Every single exercise we do has a purpose behind it. It's focusing on team communication and teamwork versus just team building. And there's a little bit of a difference with that. And so we spend a lot of time on our debrief with a focus on the teamwork and the communication. As I get to some of these exercises, this will make more sense. We also ask for a group of people to kind of be our ambassadors, whether it's in a large clinic or a small primary care clinic. And we call this the change team, as it comes from TeamSTEPPS terminology, obviously. And we focus on ownership versus buy-in. We want the frontline staff and providers to own this process. So we always like to say, you know, TeamSTEPPS is going to happen. That's not an option. You have to do TeamSTEPPS. We have to communicate better. We have to work better as a team. But you get to decide what it's going to look like. And so we work with this change team at their convenience to come up with a plan on what tools do we want to implement first. We never roll out all of TeamSTEPPS at once. We systematically roll out the tools, going back to that 100, 200, 300. It feels a lot less top-down by doing it this way. It's not something that the leadership comes in and says, hey, we're going to do TeamSTEPPS and this is how we're going to do it. That's asking for people to buy in. They get to decide what it's going to look like, and we found that very successful. So let's get into the nuts and bolts of what our trainings look like. No matter what how the length of the session, this is basically what it looks like. First of all, people want to know why we're here. And there's plenty of data out there, the Institute of Medicine report, there's the Journal of Patient Safety that John James, who is not even a clinical person, his son died because of communication breakdowns, talks about up to 400,000 people dying every year from preventable medical errors. And then there's some ambulatory care data out there. And Bishop talks a little bit about liability claims, and I apologize that I have the reference at the end of this for the 12 million patients that experience a diagnostic error. That reference is at the end of this article, or at the end of this PowerPoint. I'm sorry I don't have it on this slide. But people want to know why we're there. And then you can start comparing it to other industries, you know, the airline industry and stuff. If they had that kind of record, how many planes would crash a day, and kind of bring it to real life form. If you're doing multiple trainings, you just kind of review what you talked about in the previous trainings. And then we always have a story to tell. And our go-to story, and I'm just going to share this with you guys, was a 4-year-old child that got Afrin. She was a heart transplant child that shouldn't have got Afrin. Apparently it's contraindicated in kids that have had heart transplants. And she ended up going into cardiac arrest at home with her mom and severely injured. And it all went back to not doing closed-loop communication between the emergency room doctor and the physician, the attending physician on the telephone. You know, there's a lot to this story. It happened in our health system. And this goes back to driving home that message that you don't get to pick and choose when you use these tools. Because sometimes we'll hear, well, we use them if it's an emergency, or, you know, if it's a real big medication issue, then we'll use closed-loop communication. But, you know, if it's not a big deal, then, yeah, we're not so good at it. Well, our point is, who thinks Afrin is an important drug? And, you know, something you just go buy at the grocery store. And so that's kind of our message to open up the session. Yeah, does it bum people out a little bit? Yeah, maybe. But when you only have 60 minutes, you have to make impact. And this is one way you do it. Then we start out with a little exercise called TRIZ. And I will get more into that in a few slides, but I want to finish kind of what our training sessions look like. So we then do an introduction to the tools, and those tools I showed you on that one card where there were 7 or 8 tools, those are the tools we focus on in those short trainings. We do our interactive exercises, and then we always finish with a debrief. We're always debriefing things to try to get people to get the learning from it. So let's talk about what some of these activities look like. TRIZ comes from an organization called Liberating Structures, and I have the link to this. Actually, I think I have it on my next slide, but I'll get to it. But TRIZ is just an inventive way to do some problem solving. And so we'll start most of our sessions with something like this. How can I ensure our clinic will reliably fail as a functioning team? You know, we always go, how are we going to be a better team? How are we going to do this? But let's talk about what's going to guarantee that we will fail. And people have a lot of fun with this. Again, it starts out with, well, let's just have fun, and they'll say things. And you'll see where I have 1, 2, 4, all. That's also a Liberating Structures activity. They have like 27 or 28 activities that help kind of add to the learning process. And 1, 2, 4, all is a great activity for groups where you have people that maybe don't feel so comfortable speaking up in a large group or even in a group of 8 or 10 people. 1, 2, 4, all is, one, you look at this question and you go, how can I reliably fail as a functioning team? How can I contribute to that? Just doing it to themselves. They're not talking to anybody at this point. Then they turn to their neighbor, which is the 2. So now they're in pairs, and they share what they came up with. Then as a group of 4, they do it, and then you debrief it all throughout the entire group that's attending. So here's the Liberating Structures website, and I have it at the end of this PowerPoint too. So people always have a lot of fun with this. They throw up there, well, by not listening, by, you know, micromanaging. They come up with all kinds of different ways that we would fail as a functioning team, and then you kind of wrap that up with something like, am I doing any of these things? You have to start making people think about this stuff. Am I doing any of this stuff that's leading to us failing as a functioning team? Generally, if people came up with things that we will fail with, they're going to come up with, yeah, we do have people that do this. And so it starts making them think on that. So, again, here are some of the key tools and concepts to gain these short-term wins. Under communication, it's closed-loop communication, SBAR. On leading teams, it's brief huddles, debriefs. On situation monitoring, we look at shared mental model. How can one piece of information change an entire outcome? And then mutual support is that cuss and 2 challenge. How do we empower people to speak up when they're concerned about something that might harm a patient? I've mentioned this a couple times. Debriefing is the majority of the learning that occurs. We focus on these 3 questions. What went well? If something always goes well. And this relates to all our exercises. What could have gone better? And then one thing you'll do differently next time. And sometimes we'll change that to what's your take-home point from this? What is that one tool you will own? Always bring the debrief back to how we worked and communicated as a team. They're going to, you know, some of our simulations, our low-tech simulations, they want to go into the nitty-gritty of the sim itself, and that's fine. Give them that opportunity, but don't let that be the focus of the debrief. We want to focus on how do they function as a team. So the next exercise, and probably the one we're best known for, if you've ever seen us do any kind of TeamSTEPPS training, you may have seen this exercise. We do the team training tower, and it's a Lego exercise. And it's 3 exercises with each one becoming more difficult. So we'll start out with no TeamSTEPPS training whatsoever, have them do the exercise. Then we give them some of the tools, generally closed-loop communication and SBAR, and then we do another set of exercises, and making it a little bit more difficult using an algorithm. And then finally, the last exercise, they have an algorithm, the leader can't watch the tower being built, and the team can't see the algorithm, so it forces these TeamSTEPPS tools to be used. There's a little bit of a downfall on this one. You pretty much need about 90 minutes to do all 3 exercises and get the TeamSTEPPS training in there. Again, we cover all 4 of those concepts: communication, leadership, situation monitoring, and mutual support in that 90 minutes, focusing on those tools on that card I showed you at the beginning. Although we have done with some AHRQ clinics, we'll do 1 week, we'll do part of that, part 1, and then we'll come back and do part 2 the following week and get that way, get all 3 exercises in that way. We do have a faculty guide for this, and it was actually, this Team Tower idea came from a couple people I work with here at the University of Washington, and then it's evolved over the years, and we travel all over the country with our Legos in tow to do this exercise. But here's what the first exercise looks like, and you go through these very quickly. That's the key. You don't give them a lot of time to answer questions, and then you bring it back to the debrief. How often do we get thrown into things in the clinic setting where we're not quite sure even what's going on? And so you give them 1 minute, you tell them you have 1 minute to build the tallest tower. You must follow this building pattern shown: the 1 large, 3 small, no 2 of the same color can touch, runners can only be runners, builders can only be builders, and only 5 items per runner per trip. And all unused materials must be returned before time is called. You go through those instructions fairly quick and you say go. And it gets people going. They don't brief, they're not organized, and you find at 1 minute they may have a tower, they may not have a tower, but they'll have tons of Legos sitting on their table, and it's just been chaos. So then the debrief focuses on, did anybody take the time to brief at the beginning? Well, no, you didn't give us time. Well, you weren't efficient, so a 7 or 8 second brief would have made you more efficient. So you kind of get into the tools, and we like to say it's translating English into TeamSTEPPS language when you do the debrief on this. And we will definitely have the faculty guide for this Team Tower exercise for you to use. Again, you have to focus on the team tools. It's fun. People really like to do it. But if you don't focus on the TeamSTEPPS part of it, you lose the value of it. The second part of this exercise, again, now we give them 30 seconds to brief. We have 2 minutes to build the tower. They get an algorithm they have to follow, and in that faculty guide, those algorithms will be with you. It'll even tell you how many Legos you need for how many people. Again, going back in, runners can only be runners, builders can only be builders. And what they find, even though it's a lot harder the second time, they're a lot more efficient because they got an opportunity to brief. They've learned some of the closed-loop communication. They understand what a huddle is at this point, so they can change gears if they find halfway through the exercise something's not going well. And so you'll see that they move forward. And then on the third one, when it gets even more difficult, they generally, it's the quietest in the room. They generally get the tallest towers of the 3 exercises. And people are going, okay, this makes sense. Now, what we really like about this tool or this exercise is, and all these exercises really, it doesn't matter what your role is in the clinic, whether you're the medical director or the housekeeper or the MA or the staff RN or the physical therapist. No matter what, you're all sitting at the same table. Teams of about 5 to 6 are the best sized teams. But it doesn't matter what your role is. Everybody can play with Legos. You're focusing on the teamwork, and now maybe that housekeeper has something to contribute to this process, and they're going to feel way more comfortable in this setting than trying to figure that out in the first emergency or clinical setting that they have to be involved in. The third exercise, it looks exactly like these instructions. The only difference is the algorithm is different. So that's the Team Training Tower, and like I said, that faculty guide is available for you guys. And we're willing to answer any questions if people, my email information's at the end, if you're looking at the faculty guide and have questions. So the next one we do for really short sessions, actually I had 45 minutes about 2 weeks ago to work with a group and tried this Mr. Potato Head activity, and I got, to give credit to the people I got it from, I know a lot of people do it, but UCLA gave me this information and I adapted it to kind of fit into our really short sessions that we use here. But the Mr. Potato Head exercise is a great tool to force closed-loop communication. It also encourages them to brief huddles and debriefs, and in fact, we make them do that. And then there may be an opportunity to do the cuss, I'm concerned, I'm uncomfortable, this is a safety issue, or the 2-challenge rule. And here's what the Mr. Potato Head looks like. We have a bunch of Mr. Potato Heads. We take them all apart and throw them in a box. And there's teams, a team more than 4 or 5 is probably getting too big for this exercise. So if you have 4 people on a team, maybe 5, that's perfect. And these potato heads, this family of Mr. Potato Heads are in a motor vehicle accident. And now they have to put Mr. Potato Heads all back together just by looking at photo IDs. So we have pictures of what they should look like when they're back together. They have a triage person, is the only one that can see the pictures of the patients and must relay that information to the rest of the team. And they cannot watch what the team is doing. They have to have their back towards the group. And then they can't change roles. Once they're in that role, they have to stay in that role. Meanwhile, the people putting the Mr. Potato Heads back together have to repeat back what they hear from the triage person to make sure they're putting the Mr. Potato Heads back together. On ours, when I only had 45 minutes to work with a group and threw this in there, I give them 30 seconds to brief and select roles, and then 10 minutes to put their potato heads back together. And again, the debriefs, you focus on how is the closed-loop communication. When they didn't do closed-loop communication, you'll find that they struggle getting the Mr. Potato Heads back together. And it's just, again, a real fun exercise. People enjoy it, but at the same time, they are getting some really good TeamSTEPPS tools out of it and practicing the tools. Didactic doesn't work. Well, it does. I mean, you have to give some didactic, but you can't just speak to people for 45 minutes or an hour and expect them to maintain what was discussed in the tools. All right. So that's Mr. Potato Head, and I can send you more information about that if you'd like to. Here's, I'm going to be totally transparent on this next one, SBAR simulations. I was skeptical on this. I kind of went back and forth on this, but it started out as kind of on a whim. But what it is we give short burst of SBAR education. What is SBAR? Situation, background, assessment, recommendation. What these simulations do is it really reinforces the use of SBAR. Now, I can tell you why we really started doing this is we found by just telling somebody SBAR and throwing and I know a lot of places do this, we'll take a notepad and set it next to a telephone and they'll write on there, you know, they're pre-printed notepads that say situation, background, assessment, recommendation, and people are supposed to pick it up and use it. And I mean, that's great, but it wasn't real effective. We found that SBAR is something you have to practice to get good at. And in the clinic setting, we found it very effective in things like telephone encounters, front desk personnel communication to clinical staff and providers. In fact, that's been one of our biggest victories with that, successes with that, and just your general communication throughout the clinic. So here's what it looks like for us. And you know, normally when I'm showing these slides, I have it in an animated slide, so it's very interactive. This part is very interactive. And I'll just give them a scenario like this. This took place in a clinic in Eastern Washington, and you know, patient walks in, she doesn't speak English. There's all kinds of things going on at the front desk, and depending on what their role is, we say, well, the front desk person needs to give an SBAR to the medical assistant, or the MA needs to give an SBAR to the provider or the nurse, and so whatever their role is, they're developing their SBAR. And so the first one, we walk through it with them. So for example, this one, what is the situation? It would be a 58-year-old woman, has arrived hypertensive, is lethargic, and has a cough and is short of breath. That's the situation that's pulled out of that long narrative that you see there. Then we go to the background, the exact same narrative before. A new patient moved here from Spokane with a history of AFib and hypertension, has been inconsistent with taking meds and attending appointments, and doesn't speak English, and the daughter is interpreting. So there's the background. The assessment, her blood pressure is 178/98, her SATs are 88%, she's lethargic, heart rate's 122 and irregular. And then finally, a recommendation, I think she needs to be seen right away, and we might want to consider sending her to the emergency department. So going through that process, taking that long narrative and making it into short, concise sentences. We have them do that on the screen, working with me as I'm introducing the concept. We've had examples where we do it with, and again, I'm happy to share some of the examples I have because I have a whole list of them that I've developed over the years based on the different clinics. And I customize these to the clinic that we're working with. I don't give the orthopedic clinic an OB SBAR example. So you have to customize it, and it requires that change team I talked about. They have to be, willing to help you out with this. I'll send it to them. I say, is this realistic? Is it not? Can you edit, revise it? And they'll send it back. So by the time we do the training, it's something they go, yep, I can relate to that. They know that this occurs. So that's your basic clinical one. Here's a telephone encounter that I pulled right out of a chart, and obviously I've changed some of the information to. We also tell people to, if it's an emergency, give the recommendation first and then start back with the situation. So this was literally out of a patient's chart from a telephone encounter. And I know when I was sending in my slides, they're going, oh, there's some typos in here and stuff. I go, yeah, I know. This is exactly what it looked like in the chart. And the provider was supposed to read this telephone encounter and get information out of it. And you can see it's very long. And so I put this up on the screen and I say, okay, I give them a sheet of paper with SBAR on it. And I say, I want you guys to write an SBAR on this. And, I don't want to take a lot of time to let everybody read this, but you can tell it's very thorough, but also confusing. So what they did is they practiced, and I usually let them work in groups of 2 or 3 to come up with their SBAR, and then they report out. And here's the SBAR that came out of it. The situation is Mr. Smith called and would like his methotrexate discontinue, etc. The background, the assessment, and the recommendations. Now, remember when I first started talking about SBAR, I said I was a little skeptical about this plan. I thought of it, I decided to try it, and realized very quickly that people appreciated it. It gets great feedback because they got tired of hearing we should use SBAR, but weren't really quite sure the best way to do it. This gave them practice on doing it. Many of our clinics now, for all their telephone encounters, they'll use SBAR. Whoever's taken the telephone encounter, they will use SBAR, and it's been pretty cool because periodically I will get unsolicited emails from providers that say, hey Ross, I got this great SBAR on this telephone encounter. It was so easy to follow. I went right down to the recommendation before I read the rest of it just to make sure, there's not something that's really important that I have to deal with quickly. So the providers love this. And what we found is the people that are actually recording the telephone encounters is they like it too because it helps them focus. So this is just a couple examples. I have ones that are totally non-clinical. I have OB ones. I have GI. This one was really part of it, the GI clinic. So I have them in all kinds of different areas, and again, happy to share. Key to this is kind of make it easier for them. So I just got a half sheet of paper. I print it up, and it says, it doesn't say SBAR. It says situation, background, assessment, recommendation, so they have something to work with. And I also use that liberating structures for this one because it's pretty easy for somebody to just sit there and not say anything. So they kind of work on it on their own, then they get in their group and do it together. It's not necessarily 1, 2, 4, all. That's customizable. It's generally 1, 4, and then all. So it does encourage everybody to participate in the exercise. So next thing we focus on in these short sessions. So we're generally, if we're doing SBAR simulations, that's the majority of the session, but we still try to get introduction to some other TeamSTEPPS concepts and tools. And so if you've done any TeamSTEPPS training, you've probably seen a slide very similar to this where the bottom left photo there is a picture of a duck and a rabbit, and the next one is to the right of that is an old woman and a young woman. Up in the left corner is a saxophone player and a woman's face. It's interesting, I was doing this about a month ago and somebody said a saxophone player and Taylor Swift. which I thought was pretty specific. And then the top right one is a vase and two faces. And talk about how we both are looking at the same thing, but we might be seeing something different. And that's the key behind this. We go into the clinic, the exam room, to see a patient, and we have a good understanding of what's going on with this patient. We're both, and I'm going to simplify this, we're both taking care of the duck. We walk in, I see something, you don't see it, but you've been here longer than I have, so I don't say anything, and because if I saw it, you saw it, and now you're taking care of the rabbit, but I'm still taking care of the duck. And so we're going down those parallel paths, and the patient's being harmed because of that. So that's trying to get people a shared mental model, get them to everybody speaking up when they have something that they might add. Here's an exercise that's new that I just recently tried, and it's based it comes from the University of Colorado, which I worked with a physician here, and she and I adapted it to kind of fit our mode a little bit more. But it helps with shared mental model, and it also looks at those assumptions that break down a shared mental model. And then finally, it's just getting people empowered to speak up. And so here's the exercise. Here's what it looks like. It's a narrative. The crying child in room 602 stopped suddenly and was silent. Immediately, a man cried for help. A nurse raced to check the patient. A doctor was called. 2 medications were delivered by the pharmacist and administered. The doctor was called again. A woman with a white coat and a stethoscope around her neck entered the room and introduced herself. The doctor checked the patient and insisted he be transferred to the intensive care unit. The pharmacist asked why the transfer was necessary. 2 nurses accompanied the child in a wheelchair. So here's the answer sheet, or the 15 true or false or unknown sheet that people have to fill out after hearing that story. And in fact, I'll just show them the story on the screen so they can look back. But it's very interesting. There's another exercise out there that's very similar called Sand in the Machine. But people start going into these assumptions, and the yellow is what the answer should actually be. 99% of the people miss at least 5 questions on this because they start going into these assumptions. And it's a little hard to see this slide, but I think if you download the presentation and get it on a bigger, you'll be able to see it better. But these are the questions they ask, and people almost never pick unknown, which is the question mark. So you have them do that on their own. You let them do that on their own. You give them 2 or 3 minutes. You don't want them to spend a lot of time thinking about it. You want them to get through there. And then you get in, then you have them do it as a team. So a group of 5 to 6 people, however many are at their table. In fact, the last time we did it, we had like 10 people at a table. And they do it as a team, but they have to come to a conclusion on each one. Now you've done that, and you ask them, okay, how many on the individual level got 9 or more correct? If you got 9 or more correct, stand up. If you got more than 10 or more correct, continue to stand, and you go all the way through 15. Generally, nobody gets 15. It's usually around 12 or 13 is the highest number. Then you have them sit down, and then you ask, how many in here as a team had a higher score than you did on as an individual score? And so probably most of the people in the room will stand up, but not everybody, which means there's some people that got a higher score, but weren't able to air their reasons for that higher score with that team. So it kind of brings out the fact that, did we really empower everybody on the team to give their feedback? Did we say, hey, do you have any ideas, basically? And so it's been very effective that way. This one is it's not really clinically oriented, but it does come from a clinical setting. The Sand in the Machine one is not clinically oriented at all, but it's also great, and you can just Google that, and there's information out there on that one too. Again, people really enjoy this exercise. You get a lot of discussion on, well, I was thinking this, because you start going down these paths where you make assumptions, and as one person once said, he goes, yeah, I started going down that path and I couldn't get off it, and nobody was there to help me get off that path. And so sharing that one piece of information can really bring the team back. Okay, and then our last thing, which gets a little bit more involved and a little bit harder to do, is our stage simulations. And we do these at a very low tech. We'll have a disruptive patient or a visitor, either in the exam room or in the waiting area. and we just have somebody dress up like a patient or a disruptive patient or whatever, and they act out that role. We've done seizures in the waiting room where people have to respond. You have to, use some of these TSTEPPS concepts. You have to identify situational leaders. You have to make sure people are aware. And we really focus on not only closed-loop communication, but those tools that you see down there, the brief, subtle, the debriefs, et cetera. It's great. People tend to have fun with it, but it does require a little bit more staging, a little bit more planning to make sure your goal of the exercise is effective. We have written up scenarios of this. If people want those, we're willing to share those too. We do this a lot, especially in clinics that are just opening up, because it does help them identify environmental issues, like nobody knows where the AED is and things like that. So as we look at measurement on all these, we start really easy. Did the brief occur? One of our clinics, a huge clinic, they wanted to do a brief every morning and a debrief every afternoon, and that's the first thing they measured, was the brief occurring and did the debrief occur. And they got very successful with that very quickly. Then they started looking, did it provide any information that otherwise people might not have known? Were there any changes from the debrief? And they are starting to advertise, yeah, 40% of the time we realized something in the brief that we probably wouldn't have known if the brief hadn't occurred. And did we make any changes from that afternoon or evening debrief? We also look at some behavioral measures. The TeamSTEPPS Team Perception Questionnaire is something we use for baseline data, and then we use for, depending on the training, when the training, either 6 to 10 months after the training has occurred, to see if there's any perception of teamwork changing. And here's some of the results we've seen. I kind of mentioned this on the exercises. Improved efficiency, the physical environment, clinic flow. Some of our clinics are really looking at wait times, and they started doing things like self-rooming of patients. So we worked through that process with them using some of the TeamSTEPPS tools. SBAR especially was a big one with that. We're seeing improved employee satisfaction. One of my favorite emails was from a medical director of our pediatric clinic, and she emailed me after they did the employee engagement survey, and they had 8 people, and the clinic's not very big. It's only about 16 or 18 employees. 8 people on their employee engagement survey put on there that TeamSTEPPS was making a huge result on how they felt and working in that clinic. So that was really cool to see that. They're seeing some improved patient satisfaction because flow's going better. They're seeing clinic personnel and providers working better as teams, and we have seen improvement on the Team Perception Questionnaire survey on follow-up surveys. So again, liberating structures, I would really encourage you to go to this website, look at them. Our favorite ones are the 1, 2, 4 all, TRIZ. We do one called Troika, which we're not going to get into today. We use about 4 or 5 of these consistently, and so I would encourage you to kind of insert these into some of your education, because it actually enhances the training. The 1, 2, 4 all is just excellent, especially if you have people that just tend not to want to speak up in big sessions like this. So that's me again. I just want to show you the resources, the Institute of Medicine report, thing. That was the one on the diagnostics that I couldn't remember what it was, on the diagnostic errors. And then the TeamSTEPPS website on AHRQ, obviously. So I would like to open it up now for questions.
Hey, thanks, Ross. Wow, that was a great presentation, and you certainly gave us some exciting ways that we can make training more interactive and fun. And I've kind of been looking at some of the chats, and I see that there's quite a few that are interested in receiving samples of scenarios and clinical examples. What's the best way for them to receive those?
Well, I guess there's a couple ways. I can either send them to AHRQ group or Abby, or I can just, if they want to email me at that email, I can send them to them. And so like the SBARs, they'd get the PowerPoint for all my SBAR examples. I wouldn't just say, okay, I'll send you this one and this one. I'll send you all, and then you can pick and choose which ones you want. The scenarios, I can do the same thing. So I think the faculty guide for the teams, the Lego Tower, yeah, I mean, if people want to email me, unless somebody has a better idea from the presenter side of it, that'd be great. But I'm happy to answer questions through any email to people.
Oh, thanks. Thanks, Ross. We did have one participant that asked, how do you engage people who are worried about how to engage other people, if that makes sense?
Yeah, so
that point of speaking up.
Oh, okay. So I was thinking, well, the engagement of getting people to say, oh yeah, this is important, we need to do it, and you know, it's, people will say, oh, the providers, the physicians don't want to come to the training and stuff, and that's true to a point, but I run into that in all professions. It's not physician specific. So I'm going to answer this question two different ways, but so the key is getting the right leadership on board, and pretty much every clinic we work with, we ask that the medical director, the nursing leadership, or the clinic administration, not necessarily the nursing leadership, but the clinic administration is involved in those initial meetings. And you know, it's a little egotistical on our part, I think, but when we can get people in the room, if we can get them in there, we can get them to say, yeah, this is good stuff and it's important, and it's not going to cost me a bunch of time. That's the key. TeamSTEPPS isn't an additional initiative. It's changing what we do, how we behave, and stuff we already do. So that's a big part, which I probably should have stressed earlier, but you get them into that training and you can start making an impact quickly. But you have to have a medical director and that leadership on board to help push this forward, at least get them to the training. The second part is, how do you engage those people that just don't feel comfortable speaking up? And I think the 1, 2, 4 all, the liberating structures and all our exercises, we do that in almost every single exercise we do, whether it's an inpatient or it's a clinic or it's a 2-day training, whatever it is, we really incorporate that 1, 2, 4 all, because it forces them to talk at least to the person next to them. And then when that one thing they came up with is shared as a group, they're going, oh, yeah, you know, that was my thought, you know. And so people tend to start becoming a little bit more comfortable with that. Finally, I lied, I'm going to answer it 3 ways. The third part of this is a lot of groups we work with, they want to go right to cuss. I'm concerned, I'm uncomfortable, this is a safety issue for those of you that aren't really familiar with TeamSTEPPS. That's really the stopping the line, one of the tools for helping stop the line when something might go wrong. And we've had groups that we have to get straight to cuss. I know it's a 300 level skill, it's a culture change skill, but we have to do it because we have some serious issues. And so we go, okay, that's fine, but then we're going to encourage you to start every day with a brief. And you use that brief as an opportunity for whoever's leading that brief to, at the end of the brief, and again, we do this inpatient and outpatient, whoever's leading that brief looks to the team, and sometimes if they know somebody's really not comfortable speaking up, they'll look right at that person and say, hey Ross, you know, if you have any concerns about anything going on today, I want you to cuss at me. And you know, people kind of laugh, oh, cuss, ha, ha, ha. But what it does is it kind of empowers that person to speak up. It's a little different than what you hear leadership will say, or you know, somebody will say, oh, if I'm about ready to do something wrong, I just want people to speak up to me. Yeah, but you haven't really set that culture up to do that. So by doing this in the brief, it's a little bit different. Everybody in the room has now heard that this person wants to be cussed at. So, you know, if it was all that easy, we wouldn't need to have this webinar right now. So it does take practice, but.
Great. Thanks, Ross. I appreciate that. You know, it's was really interesting, your innovative way that you're teaching others. But as we all know, teaching and training doesn't necessarily change the culture. So if you could touch on some sustainment across your system and what you've done for that.
Yeah, especially in the clinics. To me, just from my experience, it's been easier to sustain this in the clinics than it has in the inpatient side. And I don't know that I have a good reason for that. It just seems like that's what I've seen. And so, remember when I talked about measurement, and one of the things we do is we celebrate successes very frequently, or I encourage them, the groups, to celebrate their successes very quickly. I talked about the briefs and the debriefs at the one clinic. They put up on a calendar, did the brief occur, yes or no? Did the debrief occur, yes or no? So people just had that visual to look at to begin with. So, oh God, we only did the brief 3 times this week. What happened those other 2 days? How do we make sure what happened on those 3 days it did work, and what do we build to make sure it happens 5 days this week? Then they started looking at, did the brief make any difference, and did the debrief make any difference? And so they have somebody, and that requires a little upfront work, and I can tell you in most of the areas we've done that, briefs and debriefs seem to be our most popular tools that get implemented quick in our clinics. What happens is somebody on leadership has to be responsible for tracking that information. And so a couple of things they do is make it very easy to occur. So for the brief, each clinic develops a template. We kind of guide them, but we don't tell them what that template looks like. So no matter who's there that morning, if the person that usually runs the brief isn't there, somebody can grab that template and they can run the brief, and it's standardized. In the afternoon, especially on the clinics where there's a change in schedule, or people go home at different times and come in at different times, they sit at a computer to do the debrief with an email template. And they put on there what went well, it's already set up, what went well, and they type in what could we have done better, type it in. And then finally, what's one thing we can change tomorrow? And as soon as that debrief is over, they hit send, it goes to the person leading the brief the next morning, and that person shares it with the group. So people are finding value in it. Remember I talked about what's in it for me? People are finding that there's value, and when there's a 40 to 50% of the time they're finding something about the clinic that day that they wouldn't have known without that brief, people are going, yeah, that makes a difference. We have one provider, she runs her own briefs. They have their clinic brief, then she runs her own brief with her MA and RN, and then after every patient she does a huddle, and then at the end of the day she does, excuse me, she does a debrief. And interesting enough, very quickly, she was the only provider getting out of the clinic on time once she started that. And people go, well, we don't have time for that. We don't have time for briefs, huddles, debriefs. Well, and I didn't have to say it. She shared it with the other providers. It's, look, I started these briefs, huddles, debriefs, and I'm getting out early. Well, not early, but on time versus everybody else getting out late. And so those are the kind of things that sustain it. The SBAR, I told you about the physicians, the providers have emailed me about SBARs they've gotten and how excited they were. I'm like, yeah, share that with the person that did it. So you start building on those bright spots, and people are getting rewarded for it. Again, if it was all easy, we wouldn't be sitting here, but it's made a huge difference in the sustainment, and not only sustainment, but evolving. So everybody in the clinic is starting to get behind it, going, yeah, okay, this is good stuff.
Right. It's that sharing those small wins and keeping that information open, sharing, and then seeing it as part of the routine, that it's not once a year and that's it, and go on as usual. But can you talk a little bit about how this fits into the MIPS?
Yeah, I just saw that question on there. I'd have to take a little bit more time to look at MIPS, and what I tend to do with a lot of things like the Hospital Engagement Network and other stuff is try to adjust culture, and I know this is not MIPS, but I try to develop some sort of crosswalk so it doesn't feel like you're doing this and TeamSTEPPS, right? So trying to say what tools, and like core measures is a big one too. You know, let's not reinvent or let's not make up new measures and stuff. Let's take what we're already looking at, what we're already integrating, and where does TeamSTEPPS fit into that? And that's where the crosswalk is. You know, I have to apologize. I'd have to look more into MIPS to figure out what that was. I haven't been asked that before, and to be honest, I haven't really looked into it. But I would be happy if the person that asked the question, looks like Lauren, if she would give me her information, I would be happy to look closer at it and try to maybe work in conjunction with her to develop a crosswalk for that.
Okay, great. And I think that's key, Ross, that we don't take this as a standalone or a silver bullet. TeamSTEPPS is not that, and it shouldn't be one more thing added to folks' plates, because that's, you know, the first thing they're going to balk. People are busy. We are, you know, we're all busy, but it's how do we integrate the tools, strategies, behaviors in our day-to-day work. And, you know, as you mentioned, your successes that the providers shared with you, we don't have time not to do this, I think, in healthcare today. So, you know, using this and making it fun, because we all have to come to work, right? We all have to be there, so we may as well be nice to each other and do what we can and get our patients the best outcome.
Yeah, I mean, that's key. And I'll start almost every session and say, if you don't have fun in this session, that's on you, that's not on me. But at the same time, then I finish that, but at the same time, you will come out of here with some concrete ways that you're going to improve communication and teamwork within your team. So.
Great. And I see we had some feedback on the MIPS question.
Yeah.
Thanks, Chris. It's really TeamSTEPPS is used to improve the quality of care and get to that, you know, the CMS standard. What performance measures were created by CMS? What are you following, and how do you track with those, and what needs improvement? And then looking at those tools as a mechanism for that improvement.
Right.
I hope that answered the question. All right. If there's any more questions?
So if anybody just, you see my email up there, if you want to email me directly, I'm happy to respond to those, just maybe a day or two, but I'm happy to respond.
Okay, did we have any other questions that came up that I missed? I think, one person wanted to know if you could give us quick details about the TeamSTEPPS tools that give professionals the most satisfaction and enjoyment with use.
Oh, so maybe related to some of the employee engagement survey stuff and whatnot. So what they're finding is people that have implemented TeamSTEPPS they function better as a team. People tend to enjoy working with people more when they function well as a team, and they're respected as a team member no matter what your role is on the team. So overall, we've just continued to see those places that have implemented TeamSTEPPS, inpatient and outpatient, that people are just happier, and the turnover rates go down, and their employee engagement survey scores go up. And so it's interesting that as people feel like they're a valued member of the team, that they feel a lot better about where they work. In fact, we had one group, it was an inpatient group, that not only employee engagement survey got better, but they had the highest patient satisfaction scores for 8 quarters in a row after they implemented TeamSTEPPS. Now, I won't take credit for all that, but I think TeamSTEPPS was a big part of it because patients and families saw, saw the teams functioning well and communicating well as a team.
Wonderful story. Great. Well, it looks like we're at the end of our hour here. Ross, I want to thank you so much for bringing this to us and sharing the information. And thank you all for attending. Those are some great questions, and we'll be sending out the information that you requested. So thanks all, and have a wonderful rest of the week.
Ladies and gentlemen, this concludes today's presentation. You may now disconnect your phone lines and log off the webinar.